Dear viewers, welcome you all to our show Orthopedic Solution Academy Shoulder Clinic. Dear viewers, today our topic is MRI findings of labral tear. You know that we all discuss about the various type of shoulder problems, how we can diagnose the problems, and the latest treatment such as arthroscopy, arthroplasty, and definitely the trauma management of the shoulder part. And today, our speaker is the pioneer shoulder surgeon of Bangladesh, Dr. G.M. Jahangir sir, Associate Professor, NITOR. I would like to request Dr. G.M. Jahangir sir to join with us.
Thank you, Dr. Ashraf. I am Dr. Jem Jahangir, working in NITO Dhaka. Dear viewers, my colleagues, friends, and residents, last Friday I have talked about the basics shoulder MRI. Now I am going to talk about the applied labral anatomy and tear and what are happening in this MRI findings we can from the tear. We now just know the basic of five applied anatomy of the labrum. We have to know that it is a fibrocartilage tissue in structure. It is a static stabilizer and about contribute 20% stability of the shoulder joint. And it also depend the concavity of the glenohumeral joint by about 50%. And it increase the surface contact area, buttressing the joint as well as attachment to the glenohumeral joint. All this purpose doing by the labrum. And at first, before going to the labral tear and MRI finding, we first discuss about the slab tear. Slab, that means superior labrum anterior to posterior. And this slab tear start at a 12 o'clock position and it back to the 10 and forward to the 2. That means superior labral anterior to posterior tear occur from 10 to 12 o'clock position. And at 12 o'clock position, the bicep tendon is attached. And when type 2 type labral injury, it is of the glenoid rim. That means it is detached from the glenoid rim. And like tear, there are some anatomical variants of the labrum. These anatomic variants are usually found from 11 to 3 o'clock position. When we think this injury thing, the normal variance in clock phase position. Always there is a sublabral recess from 11 to 1 o'clock position and sublabral foramen usually 1 to 3 o'clock position. We are sometimes confusing about there is a detachment of the labrum from 1 or 3 o'clock position when doing arthroscopy. Either it is tear or sublabral foramen. So you should not miss. It's like a sublabral foramen. So carefully we observe it and we do not repair it. If it repairing occur, there is a pain and complete pain after the surgery. And Buford complex, when we see there is an absence of labrum from 1 to 3 o'clock position. And in this situation, the middle glenohumeral ligament is thickened, cord-like structure, and robust. In this situation, it is called Buford complex. And labrum on MRI. Everybody should know the normal labrum demonstrates the low signal intensity on all pulse sequences due to the lack of mobile proton in this dense fibrocartilage. That means in this coronal oblique view, we can see the superior labrum and inferior labrum. All are low signal intensity. That means it is radiolucent or dark appearance. On cross-sectional imaging, labrum may be triangular, can also round, clipped, nosed, flat, or absent. And most of the time, it is a triangular in cross section. In axial cut, we can see that is anterior labrum and posterior labrum. Both are in triangular in cross section. And also see the varieties of labrum we have already mentioned that it may be triangular, or sometimes it is this rounded, and sometimes it may be uh, comma shaped or flattened, sometimes it is absent, and it also clipped and notched variety. Sometimes there is centrally increased signal intensity of the labrum we can found, and also linearly increased signal in this uh, labrum also found. These are the variety of labrum, but most of the cases it is triangular in cross section or rounded in shape. And superior labrum, that means slab tear, what we can find it is always high signal extending laterally, and margin are irregular, extend from beyond the 3 millimeter at the level of biceps and anchor and posteriorly. This is coronal oblique section. This is superior labrum. This is inferior labrum. And this is superior labrum. There is a tear. And this tear must be directed laterally. That means towards the head. And it is called the superior labral tear. And sometimes we confuse superior labral tear with the sublabral recess. We can see in the next slide what happened in the normal anatomical variant. And this is the sublabral recess in the superior labrum, and this is always smooth and directed medially, or that means towards the glenoid, and it corresponds the contour of the articular cartilage. Margin are always smooth, and it extend less than 3 millimeter and located at the level of bicep anchor. This is anatomical variant of the superior labrum and sublabral recess. So we do not confuse to see it is a superior labral tear. And in this slide, we also see the slab tear. That is in coronal oblique view, there is superior labral. This is a tear which is depicted laterally. That means towards the humeral head. So it is confirmed that is superior labral tear. And this superior labral tear, either it is anterior or posterior, we can see in the axial cut. This is anterior part, this is posterior. So this anterior part indicates this superior labrum is anterior because there is a bicep tendon, there is group for sorry, this is subscapularis tendon, and this is group for bicipital group for biceps tendon. So this superior labrum, it is anterior variety. We can find this slide. And so again, there is another slide. We can see there is a labral tear. Either this labral tear, superior labral, either it is anterior or posterior. In the coronal oblique view, we can see this is in the posteriorly directed superior labral tear. So this labral tear posterior. So superior slab tear, superior labral, anterior posterior. Sometimes it may be posterior, sometimes it may be anterior, or sometimes as a whole superior and labral tear, anterior and posterior. Next we come to the um, labrum, inferior labrum. Inferior labrum, it is either anterior or posterior. In this slide, we can see that this is the anterior inferior labrum and posterior inferior labrum. Because this is the subscapularis tendon, this is bicipital group for bicep tendon. So it is in the anterior labrum, this is posterior labrum, and all are the normal inferior labrum in axial cut section. And this is Bankard lesion. When we see that is in the coronal oblique view, the Bankard lesion, that is it is injury at the 3 to 6 o'clock position, and that is inferior. That is inferior labral. In this situation, the labrum is altered in signal changes. So this labrum is Bankard lesion tear. This inferior lesion in coronal oblique view. You can see. And another slide, this Bankard lesion in axial view, we can see that is anterior labrum, there is posterior labrum. This anterior labrum, there is altered signal changes. That means this is Bankard lesion, because this is the subscapularis tendon and this is the bicep tendon. So this is the anterior view. So it is a Bankard lesion, anterior Bankard lesion in this section we can see. Another case of Bankard lesion, that is in this section, it is a sagittal section. In this sagittal section, we can see that is glenoid fossa is pierced. This is coracoid. It is anterior, and this is the at the inferior part. This is the Bankard lesion. It is about 3 to 6 o'clock position. This is the Bankard lesion, and sometimes change in the superior labrum. So it may also associate with superior labral tear and inferior labral, that is Bankard lesion. In this situation, in this slide, we can see it. And another lesion where is commonly we can see during the arthroscopy of shoulder, Bankard lesion associated with also alpha lesion. Alpha lesion, that means anterior labroperiosteal sleeve avulsion. In the coronal oblique sequence, we can see that is inferior labrum, there is superior labrum. Inferior labrum, there is a tear, signal changes, and these signal changes extend in medially towards the glenoid neck. This is why it is called anterior labroperiosteal sleeve avulsion. That means it is alpha lesion, and it is alpha lesion always associated with Bankard lesion. It is an important finding in recurrent shoulder dislocation. Where there is recurrent dislocation, there is Bankard lesion, and there is also alpha lesion. This alpha lesion is one of the risk factor which causes recurrence rate of the dislocation. And another case of alpha lesion, in this case, that is the anterior part, that is bicipital groove. This lesion, labrum, as well as a peristeum, neck peristeum detachment, alpha lesion. In the posterior part, in this film axial cut, we also see there is a depression of the humeral head at the insertion of the tendon of infraspinatus. So we can see the Hill-Sachs lesion. Also, I will discuss it in the next slide. That is Hill-Sachs lesion, and there is Bankard lesion and alpha lesion. So it is a findings of chronic anterior instability of the shoulder. Also, another cases there is alpha lesion. There is anterior glenoid labrum and the peristeum sleeved medially and at the glenoid neck. This is posterior bicipital groove, and here is also some Hill-Sachs lesion impression. And now come we to the Bankard lesion posterior, or the reverse hill Bankard lesion. In case of reverse Bankard lesion, this is the anterior labrum, this is the posterior labrum. As because this is the subscapularis tendon, had the bicipital group or biceps tendon, and this is the posterior labrum. Here is the posterior part supraescapular vessels and nerve, and this lesion signal changes in the posterior labrum and posterior and inferior. So it is a posterior Bankard or reverse Bankard lesion. That it indicates recurrent posterior dislocation. And another slide of posterior Bankard lesion. In this is it is a sagittal cut, that is anterior, that is coracoid. This is anterior rim, and this is posterior rim. This is posterior rim. This lesion is found to 6 to 9 o'clock position. This is the posterior Bankard lesion, and it is due to the recurrent posterior dislocation of the shoulder. And another case of posterior Bankard lesion is also, you can see this is Bankard lesion posterior, but anterior labrum is intact and posterior labrum is signal changes. This is bicipital group. This is subscapular standard. This is the anterior part. You can see also suprascapular basal and snap at the posterior. This muscle is infraspinatus muscle. You can see in this axial section of the slide. And also another case of Bankard lesion posterior or reverse Bankard lesion. This is signal changes in the posterior Bankard. And there is impression of the humeral head at this level. That is a reverse Hill-Sachs lesion. We can see this is reverse Hill-Sachs lesion here. And next come to the bony Bankard. As there is soft, we discuss about the soft tissue Bankard, and now come to the bony Bankard. That is detachment of the anterior fracture of the anterior glenoid rim. It may be associated with labral tear, or maybe it is only bony Bankard, and it is better seen in basically in the CT scan. You can see that is anterior glenoid rim is fracture in the CT scan. Here it is the diagrammatically we have seen. And next slide, we can see how much bony Bankard is happen. This is anterior glenoid rim is fractured in large area. It is determine how many percentage of the bone are broken from the anterior glenoid rim. Usually when there is less than 20% bone loss anterior glenoid rim. In this situation, we go for soft tissue procedure. When more than 20% or anterior glenoid bone loss, then we go for bone block procedure like lateral Z procedure for operative treatment purpose. And this is the bony, another section of bony Bankard. In this is a glenoid. This is anterior glenoid rim, and this is the bony Bankard. And when there is less than 12%, then we go for soft tissue procedure like arthroscopic Bankard repair. When it is more than 20% or more than 12 to 20%, then we go for bony procedure like lateral Z procedure. In the also the sagittal cut, this is the bony Bankard lesion. And now come to the Hill-Sachs lesion. Hill-Sachs, there is chronic anterior instability of the shoulder. There is at the impression fracture at the superolateral part of the humeral head. In literature review, there is about 60 to 70% Hill-Sachs lesion when there is a first time dislocation, but when a recurrent dislocation, it is about to 80 to 90% recurrent dislocation. And when this Hill-Sachs lesion is usually more than 40%, we go for remplishas. When more than 40% Hill-Sachs lesion total surface area, then we go for bone grafting or other procedure. And also when there is a this Hill-Sachs lesion is engaging Hill-Sachs lesion, then we go for also remplishas. When it is non-engaging Hill-Sachs lesion, and in this situation we can do only Bankard, but engaging Hill-Sachs lesion we go for Bankard and remplishas. In this slide, the axial cut section, we also see that is how many breadth and length of the hill circulation at the posterolateral part of the humeral head by assessing, and from where the total how many percent is bone loss from the humeral can be detected. And in the coronal oblique card, you can see there is a large Hill-Sachs lesion just below the at the insertion site of the infraspinatus or posterior part of the supraspinatus and infraspinatus and this oblique. And also, this is a axial card. This is see we see the Hill-Sachs lesion is there here because this is the infraspinatus tendon, and here is the uh, bicipital group here, and that is subscapular tendon. And thanks for patient hearing.
Thank you very much, sir, for your nice and excellent presentation. We have learned many things from your valuable slides, and hope our junior doctors will learn many things from you. Thank you very much, sir, and hope we will connect with the next Friday with another excellent academic topic regarding the shoulder joint. And till then, I would like to thank all of our viewers to join with us, and I would like to thank Raj TV for helping us to organizing this type of programs, and definitely Malia CNT Specialized Hospital for sponsoring our program. And I'm Dr. Mahmoud Tanvir Ashraf. Again, thanks all of you and saying bye bye to all of you. Hope we'll connect in the next Friday. Till then, bye bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.